So I think, before we even get to choosing which one, we sort of want to get people to at least consider the possibility of using an LAI, and the fact that they have so many different options now, I think should make it somewhat easier. One of the questions is also how early would you propose the use of LAIs? And I mentioned earlier that some of the guidelines suggest you should wait until someone's demonstrated non-adherence repeatedly. My view is you really want to prevent as many relapses as you can from the get-go. So when we're asked, would you use an LAI in a first episode patient, I would say yes, because we really don't want that person to relapse. We know that the extent to which you can get the illness under control in the first couple of years is a very powerful prognostic indicator. So I really want to do everything I can to prevent that first relapse. And we go back to the data we cited earlier, that with each relapse, the response may be less good than it was the last time. We may be on a pathway to treatment resistance. So we want to avoid all those things. And when I think about some of the first episode patients that we treat who do really well following their acute hospitalization, they go back to school or back to work and they feel great, everything's fine. Those are the people who often want to stop their meds and often get into real difficulty and lose a lot of the gains that they've made. I think if we can offer them injections from the get-go, make it easier, they don't have to take pills in front of their roommate, they can just go to a clinic or to a doctor and get an injection once in a while. It makes it, I think it can make it much more comfortable. So we've actually recently done a study with several hundred first episode and early phase patients, and we got about 86% of them to agree to injections. But the way that was done was going out to the clinical teams and training them on how to have the conversation with the patient. First, educating them about the whole concept and how to use these drugs. But the key thing was, how do I talk to what do I do when the patient says, no, I don't like needles, or no, I don't want an injection? You don't just give up. It's a conversation. And Peter Wyden published an interesting paper in the Journal of Clinical Psychiatry a few years ago where they recorded the conversations between doctors and patients about LAIs. And it was almost comical, some of the things that people said, even though they knew they were being recorded. So we take for granted a lot of our ability to have conversations with patients, but I think it requires training. It's not something that just comes naturally.
What kind of stuff, was there some sort of script? I mean, were there some specific turns of phrase?
But there was also
helped?
Role playing. So that we sat with the doctors and we said, okay, what would you say? I'm the patient and I'm saying, no, I don't want to do this. What are you going to say? And I'm trying to give him as hard a time as I can. Get him comfortable, really having this conversation, and not in a pejorative way, but let's try to be really constructive.
What about nurse practitioners?
I think same thing. I mean, to me, the other thing that was important in this project was the whole clinical team. So if I'm a patient and my therapist is a social worker who thinks that injections are terrible, he or she may undermine the whole thing. So that person also has to be on board.
I think that's smart. I mean, that's what you were sort of alluding to that earlier, Jeff. That if the social work team is anti-shots, then it's a problem.
Yeah, and some of the studies that have been done recently suggest that patients have a much closer relationship with their therapist than they do with their prescriber, right? So that person needs to be supportive of the whole thing. And then families, I think, families can be very important advocates for this. You think about what happens when the family, if you have a loved one who's had a psychotic relapse and has lost insight, and you have to call the police to take that person to a hospital, have them hospitalized against their will, what a traumatic experience for everybody. So when that person is discharged from the hospital, it wouldn't be surprising for the family to be reminding them to take their medicine or concerned about whether they're taking their medicine. If you have long-acting injectable formulations in the picture, you've eliminated that family tension, which I think can go a long way. So I'd say families are important. Also, what about peer counselors? I don't know if you guys have had experience with peer counselors, but many people feel that if you have someone with lived experience, that they can communicate more effectively with the patient.
The one thing, I think it's a great idea. I know that some peer counselors or people who train peer counselors have been concerned that they feel like they're being co-opted by the system. Okay. If they're sort of on the take meds team. I don't have a problem with that, but I've heard that's an issue.
What about, do you think that if there were oral long-acting medications, that there would be less resistance to using them?
I think that would be a nice addition to the alternative options. I mean, we did an experiment a long time ago with a once-weekly oral that never made it to market, and it worked quite well. So I think, yeah, that would be a nice option to have.
Is penfluridol?
That was penfluridol, yeah, diphenylbutylpyridine. But some of the current drugs have long half-lives, so they could conceivably be given less than every day. I think some people worry that, okay, if I'm taking an oral medicine once a week and now I miss that, then I'm really in trouble. But you could have that supervised But I think, to me, the more options we have, the better, because you have a better chance of finding something that's going to work for that particular patient.
Well, if injections are a deterrent for whatever reasons, then I suppose implants are going to be even more objectionable.
Yeah, but people have experimented with that. I mean, it's certainly feasible to have implants.
Are there some in development still, or?
I've lost track of what, I know Steve Siegel was doing that at Penn, but I've lost track of what happened with that.
So one more thing about long-acting injectables that I was saying, in terms of, who to recommend them for, what about, people who smoke pot? Is that you?
So personally, I think if I have someone who's smoking a lot of pot, I would be more comfortable if they were also getting a long-acting injection, because then I know they're not going to stop their medicine on Saturday because they say, I want to get stoned tonight, and I would sleep better at night knowing that they're on an injectable medicine.
Is there a second or third generation antipsychotic that you would like to see an LAI developed for?
It'd be great if we had one for clozapine, right? But that's not going to happen. I think, well, yeah, it's a question of formulation. Some medicines don't lend themselves to long-acting formulations, but
I mean, I think the fact that we have Invega, which is palperidone, and aripiprazole, that represents a good sort of spectrum.
Mm-hmm.
I mean, it'd be nice if olanzapine wasn't troubled by this, but it shouldn't be an absolute deterrent.